Our next speaker is Dr. Greg Avey from the University of Wisconsin, who will be speaking about sinonasal masses.
So hello, my name is Greg Avey. I'm pleased to be with you. I'm going to present on sinonasal masses, the good, the bad, and the ugly. I'm from the Department of Radiology at the University of Wisconsin School of Medicine and Public Health, where I help to serve as the Director of Head and Neck Imaging. As to one disclosure, I'm a consultant for GE Healthcare, mainly on CT-related issues, nothing to do with the paranasal sinuses or sinonasal tumors. So my goal in this talk is to demonstrate the interesting breadth of pathology found in the nasal cavity and the paranasal sinuses. We're describing new tumors in this location virtually every day, and we have new insights on the pathogenesis of those tumors. And I hope to help bring some of those to light during this talk. So during this talk, I'm going to describe the incidence and the demographics of sinonasal tumors. I'm going to discuss how we separate tumors from inflammatory changes, which I think is one of the most important things we can kind of do at the PAC station. I'm also going to go over common and notable histologic types of sinonasal tumors, and I divide those into the good, the benign tumors, bad, and ugly. And unfortunately in this area, bad and ugly tumors seem to predominate the discussion. So first of all, the incidence and the demographics. These are relatively uncommon tumors. The yearly U.S. incidence is about 3 in a million. That's 3 to 5% of all head and neck malignancies. So if you read a fair amount of head and neck, chances are you'll see several of these a year, but it's not going to be something you're going to see every day in your clinical practice. Approximately 75% arise in the paranasal sinuses, largely within the maxillary sinuses, and about 25% occur in the nasal lines. For the demographics of paranasal sinus tumors, I usually think of Statler and Waldorf, my two favorite critics up here. 2/3 of patients are men, 50% between the ages of 60 and 79, and only 4% from patients less than 40 years of age. So if you see a relatively young patient with a sinonasal mass, obviously it could still be a tumor, but it's somewhat less likely just based on the demographics. Where do these occur? Predominantly in the maxillary sinuses, about 57%. About 25% of the nasal cavity and ethmoids, and then a vanishingly small number in the sphenoid sinuses and the frontal sinuses. I think the literature really only has a case series of 50 or 60 tumors occurring in the frontal sinuses. So you're sitting at the PAC station reading your typical sinus CTs. How can we help make sure we separate tumors from the relatively ubiquitous inflammatory changes? Well, that can be very challenging for early T-stage tumors. One thing that can help is high CT density on CT. Most inflammatory lesions are much more watery and will be lower in CT density, like this retained secretions in the left maxillary sinus, whereas the squamous cell carcinoma of the nasal cavity is about 60 Hounsfield units, or approaching the density of muscle. Contrast enhancement can help, but it's rarely performed for screening examinations. A tumor like this, where we have destruction of the maxillary sinus, the floor of the orbit, the ethmoid papyration, it's pushing the extraocular muscles laterally. Obviously, I think that most of us are going to recognize that advancing tumor any day of the week. For more challenging cases, though, like this one, this was originally described as a post-surgical change with a maxillary antrostomy and some kind of cleaning out of that left maxillary sinus. Instead, the next radiologist who was actually relatively astute and noticed that there wasn't a really conventional maxillary antrostomy. Not only that, it was relatively high in CT density, and there was effacement of the fat within the pterygopalatine fossa. So here we see the pterygopalatine fossa, sphenopalatine foramen both had normal fat here. It's been effaced here on the left due to this patient's squamous cell cancer. On MRI, how do we separate tumors from inflammatory change? We can kind of use the water content to help us out. The majority of tumors will be low in water content, and so will be isointense or hypointense on T2 weight images. There are some exceptions for the glandular tumors, particularly minor salivary tumors, schwannomas, polypoid tumors such as inverted papillomas can sometimes be MRI T2 hyperintense as well. Contrast can also help in distinguishing tumor from adjacent secretions. So here's a case study just showing all the various contrasts of typical sinonasal tumors. So here we have T2 hyperintense secretions trapped within the ethmoid air cells in the sphenoid. We can see the T2 hypointense tumor, which really courses along the nasal cavity and the ethmoids and even along the intersinus septum back here. That's confirmed on the PET MRI, where you have nice localization of the metabolic activity of that area. And then on the post-contrast images, we can see kind of a hyper-enhancement of the adjacent nasal mucosa, much more so than the tumor itself. So the tumor has sort of an evil gray kind of intermediate enhancement, whereas the nasal mucosa is typically more enhancing than the actual tumor itself. On the non-contrast CT images, it's pretty hard to separate tumors from inflammatory change. It's maybe a little bit more CT hyperintense. But I would point out on the initial images, we did see a red flag finding that the patient had isolated olfactory cleftopacification, which is something that we should be thoughtful of. Obviously, that's sort of the last place that usually opacifies. So if you see opacification in that area, first of all, you need to be thoughtful about that and potentially do a little more workup. This actually turned out to be a squamous cell cancer, which even on magnified views here, we can see extending up through the skull base and involving some of the dura just along the cribriform plate. So that's going to require a little bit more of a resection than just the initial resection that you can see occurred there before they did a full, more complete staging workup. In general, benign collections will either be high in T2 signal intensity due to increased water, or they're going to be high in T1 signal intensity due to increased protein within insipated, desiccated secretions. So one of the things I train my fellows and my residents is to consider a mass which is low in both T2 signal intensity and low in T1 signal intensity as being a little bit suspicious and needs further evaluation, further workup, or at least further thought. So now we'll go on and talk about some common and notable histologic types of sinonasal tumors. We'll start with the good and or the benign tumors. The first of which is a relatively recently described entity, the respiratory epithelial adenomatoid hamartoma, quite a mouthful, or RIA as I like to call it. It's a benign hamartoma with respiratory glandular proliferation. It follows the rest of our paranasal sinus tumors in having a male predominance, so 7-to-1 male, and it often is associated with the widening of the nasal cleft. So we just talked about that isolated olfactory cleftopacification, how that can be kind of a worrisome sign. About half the time when I find that isolated olfactory cleftopacification, it's due to this entity, the respiratory epithelial adenomatoid hamartoma. Here's a case. We've got this slightly CT hyperintense mass centered within the piriform aperture and the anterior sort of vestibule of the nasal cavity. On the T2-8 images, we see a little bit of a heterogeneous increased T2 signal intensity. On the T1s, it goes almost all the way up to the anterior skull base, and here it is on endoscopy, just hanging down there from the olfactory cleft. And again, that's benign. Inverted papillomas are also benign, but can be locally aggressive. It can also carry a 15% risk of developing squamous cell carcinoma ex inverted papilloma. It can be locally recurrent, so traditionally it has been managed through non-block resection. Honestly, my surgeons typically now will do an endoscopic resection and then will perform endoscopic and imaging surveillance to evaluate for recurrence, which has in the past been a challenge. Locally enough, honestly, I haven't seen a lot of these recur coming across my desk. Pathologically, these consist of squamous epithelium replacing the mucosal ducts and glands, and typically they originate classically from the lateral nasal wall. These are often erosive, leading to bone fragments within the mass in about 40% of patients when they present de novo. Interesting and somewhat helpful sign is that the area of hyperostosis is often present along the stalk at the origin. So it's helpful both in identifying the potential for inverted papilloma if you see an unusual osseous stalk in the nasal cavity of the paranasal sinuses, and it's also helpful for guiding surgery because they have to go in there and resect that area, and that's sort of their thought process for their surgical approach, is making sure that they can get good exposure of that area of the stalk. Classically, it has a cerebriform appearance on both T2 and post-contrast T1-weight imaging, but that's not universal. Interestingly enough, there's only two mutations really that have been associated with inverted papilloma development. The first is an EGFR mutation, which is found in 91% of cases in a recent series, and then a relatively low-grade or so quote-unquote low-risk HPV infection, HPV 30 and HPV 33, is found in approximately 9% of cases. The EGFR mutation is particularly of interest because we do have chemotherapeutic targets for the EGFR receptor, so that might be something that we can use in the future, especially for squamous cell cancer ex-inverted papilloma. This is a case of a inverted papilloma. Here we can see an unusual opacification of the anterior ethmoid air cells with an osseous stalk down the center going through the middle meatus. We can see that stalk goes all the way up to the lateral nasal wall, and this was the relatively large stalk associated with an inverting papilloma, which is causing a left OMU pattern of obstruction of the paranasal sinuses. Here we can see a separate patient where we can see, again, relatively CT hyperdense mass within the left nasal cavity and going to the left maxillary sinus, a small rim of hypointense material around it, which is the trapped secretions. That made us think that there was potentially an underlying mass, and the patient went on to get an MRI. And here we can see a more classic sort of MRI appearance of the same, with a cerebriform appearance, that sort of undulating, heterogeneous appearance, and then peripherally the trapped secretions. And again, on post-contrast imaging, also has that same cerebriform appearance. The squamous cell carcinoma makes up approximately 65% of the tumors of the paranasal sinus and the nasal cavity. it's associated with industrial exposures, especially things like wood dust, nickel, and chromium, although as we'll talk about later, wood dust is actually more associated with adenocarcinoma than it is squamous, but it does have some association with both. Approximately 15% of patients will present with nodal metastasis. That's especially true if they're spread to the premaxillary soft tissues, the orbits, or the pterygoids. And local recurrence is actually relatively common. It occurs in 20 to 50% of cases, and most of those will occur within 1 year. So the moral of the story being, if you're reading a 1-year follow-up in these patients, you need to be very thoughtful and very careful for looking for subtle signs of recurrence, because it's often relatively common for these maxillary squamous cell carcinomas. 5-year survival is relatively dismal, approximately 30%, and really hasn't improved much over the last 40 years. You would expect with all the potential new options in resection and with chemotherapy that we'd have some improvement in survival. And at least up to this paper, which took data up to 2009, we haven't had much improvement in survival. Although now we're having more delineation of the various molecular targets, I'm hoping that's going to improve in the next round of data. And speaking of some of the molecular targets, so we kind of recognize that keratinizing squamous cell carcinoma is more associated with tobacco exposures and other types of exposures. There are also some non-keratinizing subtypes which occur in the nasal cavity and the paranasal sinuses. Those are more associated with HPV, particularly the higher risk HPV subtypes. So you're talking about type 16 and other types of HPV. And approximately 20 to 30% of sinonasal squamous cell carcinoma harbor an active high-risk form of HPV. Like in other places, HPV, although it does have a greater tendency to cause these tumor types, it also has some positive effect on outcome. And the HPV positive tumors did have a 5-year overall survival of 68% versus 52% for HPV negative tumors. So some positive survival advantage accruing to those with HPV positive tumors. It's a pretty classic squamous cell carcinoma of the maxillary sinus. Here we can see a mass running through the orbital floor. It's extending outward anteriorly along branches of V2 into the premaxillary fat. It's also extending posteriorly into the pterygopalatine fossa. It's causing some mass effect on the globe itself, so there's hyperglobus with superior displacement of the globe, which you can actually see on the patient's physical exam image as well. On MRI, we can again see that extension anteriorly into the premaxillary soft tissues along V2. Posteriorly, extending along V2 to the pterygomaxillary fissure through the pterygomaxillary fossa and up to foramen rotundum, which then goes into the cavernous sinus. So relatively extensive perineural spread tumor in this relatively classic squamous cell carcinoma of the maxillary sinus. Adenocarcinomas make up a lesser percentage, but they're the second most common tumor of the perinasal sinuses and sinusal cavity. It makes up 13%, so if you have to make a guess, squamous and adenos make up about 80% of tumors of the nasal cavity and perinasal sinuses. It's divided into two different types, an intestinal type adenocarcinoma and a sinonasal adenocarcinoma, the SNAC type. The intestinal type adenocarcinoma is associated with wood dust exposure and leather dust exposure. And in fact, the association with wood dust exposure is pretty significant. It increases the risk 900 times over the general population as an option whenever you can. So adenocarcinoma, because it is glandular, can be more T2 hyperintense than squamous cell carcinoma. It has a similar demographic as squamous cell carcinoma, with a mean age of 64 years and 75% male, and a pretty dismal 5-year survival rate of about 50%. Because it is associated with those sort of central exposures and those exposures to toxins in the environment, it does have predilection for the nasal cavity and the ethmoids, and it should be on differential of most of our nasal and paranasal sinus masses, but particularly those with a central location and those that have a history of woodworking or other types of exposures. There are also some minor salivary tumors in the nasal cavity and paranasal sinuses, and these in general follow the rule of salivary neoplasms, that being that the smaller the salivary gland, the greater there is the chance of harboring a malignant neoplasm. Adenoid cystic is the most common pathology, with most presenting with T3 or T4 stage disease, almost 77%, but interestingly enough, relatively few having distant local or distant metastasis, so N0 status in 98% and no metastasis in 97%. They have really good 5-year survival rates of 71%, but given adenoid cystic is so sort of indolent and gradually progressive, a 10-year or a 15-year survival rate is actually probably more important than just the simple 5-year survival rate, because adenoid cystics will just essentially continue time over time. And we certainly have several patients that we're following up that have had their adenoid cystic for 10 or 15 years and have had multiple resections of them. So this is a patient with adenoid cystic carcinoma. Again, looks much like that squamous cell carcinoma, We can see extending anteriorly along V2. We can see the trapped secretions on this T1 weighted image. And we can even see some tumor or something, at least along the alveolar recess of the maxillary sinus. And by the way, a little bit of tumor in the anterior-palatine fossa posteriorly as well. Take the T2 weighted image, it's relatively cellular, little T2 hypointense. We can see it's contrast enhancing, extending through the maxillary sinus, going backwards along the nasal cavity to the sphenopalatine foramen, going backwards along branches of V2 and palatine fossa. And here we can see the posterior superior alveolar nerves that are along that posterior wall of the maxillary sinus. They're enlarged, thickened, and enhancing. So this is perineural spread of the tumor along the posterior superior alveolar nerves, which helps supply the molars and the maxillary molars and the maxillary premolars, which is a good explanation for why we have a little bit of tumor sitting there in the alveolar recess. A variant of squamous cell carcinoma that used to be classified along with adenoid cystic carcinoma and probably was confused for adenoid cystic carcinoma for a number of years has been newly recognized by the WHO. It goes by the relatively long name HPV Related Multiphenotypic squamous cell carcinoma. It's identical to adenoid cystic carcinoma on histopathology. It's HPV positive but lacks the characteristic gene fusion, the MYB gene fusion of adenoid cystic carcinoma. And interestingly enough, it behaves very differently compared to adenoid cystic carcinoma. It doesn't show the propensity for perineural spread that adenoid cystic does. So a newly recognized carcinoma with a relatively good prognosis compared to others. Olfactory neuroblastoma, this is the classic high anterior nasal cavity mass. It has bimodal peaks in the second and sixth decade. It arises from the olfactory mucosa along the superior nasal cavity, often has intracranial extension, and with peritumoral cysts are sort of the classic thing that you would find between the brain parenchyma and the mass. It has its own staging system, the Cadish staging system, and 30% with metastasis. And olfactory neuroblastoma, almost like adenoid cystic carcinoma, can be relatively indolent with a late recurrence. Some of those can be 15 years or longer. So oncologic follow-up at least 10 years is usually recommended in these patients, and sometimes longer, just to the long history and kind of indolent course of a lot of these olfactory neuroblastomas. Olfactory neuroblastomas can also be difficult to diagnose on pathology. They're a small round blue cell tumor, and they exist on a continuum with sinonasal neuroendocrine carcinoma and sinonasal undifferentiated carcinomas, and can mimic many other small round blue cell tumors. Overall, if you have an accurately diagnosed olfactory neuroblastoma, the prognosis is pretty good, with a 75% 5-year survival rate. So here you can see many of the other types of tumors which have been confused in the past with olfactory neuroblastoma. So here you see the olfactory neuroblastoma with a mass again along the anterior skull base. There's a little bit of extension through the anterior skull base, and it's trapping secretions within the sphenoid, creating this T1 hyperintense sphenoid sinus as well. Here you can see the inferior extent of the tumor. When we give contrast, we have a better sense of just how much is extending through the anterior skull base and involving portions of the dura and the anterior falx. And because it is a cellular tumor, it's both diffusion restricting and a little bit T2 hypointense. This is a separate patient who discovered a mass along their chin line while shaving. You can see a relatively large, prominent level 1B mass, a couple of level 2 and level 3 nodes on the left. The patient had a known history of basal cell carcinoma, but of course that would be a really unusual presentation for basal cell carcinoma. So we kept looking for other potential causes and came up with a mass along the anterior nasal septum, kind of an unusual ovoid or spindle-shaped mass just along the left side of the nasal septum. We then did a PET MRI to further evaluate disease and to see the full extent of disease. Here we can see it's a little bit T2 hypointense mass with a little bit of contrast enhancement. Again, just like most of these sinonasal tumors, not as much enhancement as the adjacent mucosa. Also, interestingly enough, we've got a little rounded mass within the left maxillary sinus. Under most circumstances, I would dismiss that as being inflammatory, but it's restricting diffusion just like the rest of the olfactory neuroblastoma, and is showing the same uptake on the PET MRI. So in this patient, we had 2 foci of olfactory neuroblastoma, one in the nasal septum, one in the left maxillary sinus. The basal cell was just sort of hanging out there doing its own thing. And then here we can see the metastasis, the level 1B and level 2 and level 3 lymph nodes as well. There are other sort of more aggressive tumors of the perinasal sinuses as well. The sinonasal undifferentiated carcinoma is probably one that comes most to mind. This is the least differentiated of the tumors on the olfactory neuroblastoma, sinonasal neuroendocrine carcinoma, sinonasal undifferentiated carcinoma spectrum. It used to be a pathologic dose, or I guess probably still is a pathologic diagnosis of exclusion. It's extremely rare and very aggressive, and has a high propensity for metastasis and really aggressive intracranial extension. Interestingly enough, approximately 50% of sinonasal undifferentiated carcinomas, the SNUCs, have been found to have IDH2 mutations. So just like we talk about IDH mutations in gliomas, we're now finding them in SNUCs as well. No other sinonasal tumors were found to have IDH mutations, so it might be a potential helpful diagnostic test as well. And it does prompt the thought process, will SNUCs be a differential diagnosis exclusion for much longer now that we have a relatively specific test, at least for some subset of the SNUCs. Here's a classic undifferentiated carcinoma. We can see a relatively homogeneous mass extending all the way up to the anterior skull base and even causing some erosion of the ethmoid air cells clear at the top. On MRI, it's almost homogeneous. It looks like a small round blue cell tumor, very homogeneous, almost monotonous in appearance on T2. And then we can see the same thing on T1, very homogeneous in appearance, not a lot of flow voids within it. And then here we can see on the post-contrast imaging, it's extending all the way up to the anterior skull base, just barely touching the left frontal lobe. So this was aggressively resected and radiated, and then re-resected, and then treated with proton beam therapy. And despite all that very aggressive surveillance and treatment, this tumor just wouldn't stop, and you can actually see this patient with the necrotic tumor advancing through the frontal lobe almost all the way to the left basal ganglia, and this patient then succumbed to their disease not long after that image there. So unfortunately a relatively common end pathway for SNUC tumors. Another thing that can look like SNUC but it's not is the SMARCB1 deficient tumor. It's a newly described entity. It's another small round blue cell tumor, and it has the loss of the SMARCB1, which is a tumor suppressor gene. There's no loss of IDH2, but it has a similar sort of survival curve as SNUCs with a 22-month mean survival. Another aggressive tumor is the Sinonasal Melanoma. This is a relatively rare tumor. It can be both melanotic and amelanotic, with 40% not having melanin, being amelanotic. The melanotic melanomas are typically T1 hyperintense, but both of them will be T2 hypointense due to their cellular nature. The interesting thing about this tumor, has a very poor prognosis. In fact, the AJCC staging system for sinonasal melanoma starts at T3 because there's only a 17% 5-year survival rate, and systemic metastases are very common. So here's a mucosal melanoma. We can see it extending just anterior to torus tubarius. Here it is intrinsically T1 hyperintense. Questions later on here. Here's a classic sinonasal melanoma. We can see T1 hyperintense tumor filling nasal cavity involving left maxillary sinus, and then it's spilling down level 2 and level 3 lymph nodes with T1 hyperintense lymph nodes. Interestingly, we compare this to cutaneous melanomas. They have different mutations and different survival rates. Cutaneous melanoma, there's a 90% survival rate. Mucosal melanoma, 14% survival rate. We have targets for BRAF and KIT, which are relatively common mutations for cutaneous melanoma. Unfortunately, for sinonasal melanoma, there's a whole host of potential mutations. 30% have this NRAS mutation, which unfortunately right now does not have an oncologic target. Last but not least, we're going to talk about the nut midline carcinoma. This is a genetically defined highly lethal cancer which results from rearrangement of a nut carcinoma, a nut gene on chromosome 15q14. It typically arises from midline locations, particularly in the head and neck and mediastinum, and median survival is less than a year. So this is a gentleman who presented with a frontal sinus mass. You can see it's very aggressively extending through the anterior table of frontal sinus, pushing the frontal lobe backwards, extending anteriorly along the falx. This patient underwent a relatively heroic resection, flap reconstruction. They got gross total resection, which I was really impressed with this. Post-operative imaging looked totally clear. He comes back 3 weeks later and has these, centimeter and a half, really aggressive and cellular-looking metastases or local recurrences. You can see extending to the left orbit and through some of those areas, which were right at the margin. So, a highly aggressive tumor, very difficult to clear. The second nut carcinoma, this is a 44-year-old woman who presented with headache and blurry vision. We can see a mass in the left frontal sinus extending just anteriorly. Originally thought it might be Pott's puffy tumor, but because it was a little untypical, they brought him back in 3 weeks to image. Here you can see we now have a much more well-circumscribed lobulated mass rising from the left frontal sinus. We can see the enhancement pushing out the periosteum just anterior to the left frontal calvarium. It initially responded to chemotherapy, but then she presented with increasing pain, and we did a PET MRI to help evaluate to make sure it wasn't post-surgical change in there. You can see the very intense hypermetabolism separated from the left frontal lobe on PET MRI. She underwent multiple rounds of chemotherapy, only minimal effect on the tumor. They did a full orbital exenteration and flap reconstruction, and then she presented with aphasia and concern for stroke. Here you can see the flap reconstruction. This was initially thought to be potentially a subdural hematoma, but after they took a look, With MRI, we can see there's this big, thick, caking rind of enhancement along the dura, extending along the falx, and then even a couple of abnormal lymph nodes on that left side as well. So just massive recurrence in this patient within just 6 months of being diagnosed and highly aggressively treated for nut carcinoma. So the take-home points: sound nasal neoplasms are rare, but they're very important entities. We need to think about older males for demographics typically, but not exclusively. And then high-quality imaging and detailed anatomic knowledge are key to helping guide appropriate therapies. There is a significant developing literature on the oncogenesis of these tumors, so we need to anticipate future changes both in how we characterize and how we diagnose these masses.
Our next speaker is Dr. Elchin Zahn from NYU Langone, who will be speaking about the role of dotatate PET imaging for esthesioneuroblastoma.
Welcome, everyone. This is Elchin Zahn from NYU Radiology. Thank you very much for joining us on ASHNR's 54th annual and the first virtual meeting. I would like to thank Dr. Schmalfuss and the organizing committee for inviting me and for putting together such an excellent meeting under the COVID-19 related circumstances. I will talk about the role of gallium dotatate PET in esthesioneuroblastoma. I don't have any relevant disclosures to the topic here. Esthesioneuroblastoma has multiple clinical and radiological features that we can talk about, but I will emphasize the most common ones. We will discuss a few case examples and identify patient management problems, and the gallium dotatate PET radiotracer. We will discuss what it looks like and how it can be used as a problem-solving tool. Esthesioneuroblastoma is a rare malignancy. It arises from the olfactory neuroepithelium that lines the cribriform plate, superior aspect of the nasal septum, middle and superior turbinates. So in that setting, the intricate anatomy of the cribriform plate, intracranial fossa, and the nasal cavity creates a direct access for disease progression into the intracranial compartment, orbital compartment, and the paranasal sinuses. And the local extent of the disease identifies the patient's presenting symptoms. The presentation could be as simple as unilateral nasal obstruction or epistaxis and as complex as headache and diplopia. The treatment is primarily surgical resection of the mass, but it can be followed by adjuvant radiation or chemoradiation if the adverse features exist. We will see those in the next slides. Esthesioneuroblastoma, despite being a rare nasal malignancy, it is associated with increased risk of local recurrence in 1/3 of the cases, and the distant metastases are as common as the regional recurrences. And in that setting, we need a good systemic screening diagnostic tool, and FDG PET-CT has been doing a pretty good job so far. The FDG PET-CT has changed 40% the disease management in esthesioneuroblastoma patients due to better recognition of the nodal and the metastatic staging. However, this improvement is still not good enough because the 10-year survival is still lingering around 52%. So I believe with better molecular imaging methods, we can improve that number. So the prognostic factors of esthesioneuroblastoma that define whether the patients get post-surgical radiation or chemoradiation are listed here. We will dismiss the high-AMS pathological grade because it's beyond the scope of this talk, and let's focus on the caddish clinical staging. It's pretty simple actually, and heavily dependent on the imaging. It answers a basic question: where is the mass? The caddish staging takes the mass extent into account, and it depends whether the mass is confined to the nasal cavity, involves the paranasal sinuses, or extends beyond these two structures. And prognostic factors also include positive surgical margins, positive nodes, elderly age, and male gender. Let's discuss our first real case. Typical imaging features of esthesioneuroblastoma. On this post-contrast CT imaging of the face, we see an obstructive soft tissue mass at the nasal cavity with associated erosion of the cribriform plate and this nodular extension into the intracranial compartment. The orbital compartment is free of disease. The nodular, dural-based nodular, enhancing component of the disease is much better seen on the post-contrast T1 weighted sagittal projection with fat saturation. And the other MR parametric features are reduced diffusion due to high cellularity and diffuse enhancement. As a part of the initial metastatic workup, the same patient was also imaged with FDG PET-CT. And as clearly seen here, there is no nodal disease, there is no metastatic disease, no bone, liver, or lung lesion is found. However, when we have a closer look to the primary disease, the local disease evaluation, we can clearly see that the Ostiomeatal Neuroblastoma itself is a mild to moderately FDG positive disease, and even if it was markedly FDG positive, it would have still suffered from a fundamental problem here. Look at how hot on FDG PET, how hot the brain cortex is, and even if you have an S-hot mass at the skull base, it would be impossible to differentiate the mass from the brain cortex. Nonetheless, the Ostiomeatal Neuroblastoma is mild to moderately FDG avid, and you can see that the brain mass interface at the skull base is really obscured by the brain activity, and we cannot confidently evaluate the intracranial extent of the disease. So let's keep prognostically staging our patient. She had Himes pathological grade 2/3 and Kaddish stage C because of the intracranial extent. Surgical margins were positive, but no nodes were found on the FDG PET-CT. Another adverse feature was her age, but her gender was a favorable feature here. So because of these adverse features, Kaddish stage C, surgical margins being positive, and the Himes pathological grade, the patient was further treated with local radiation. And as a part of the routine post-radiation follow-up, she got this MRI. We're looking at an enhancing nodule in the inferior frontal lobe and in the anterocranial fossa. This is exactly where the mass was taken out. So for the most experienced radiologist, this probably is a slam dunk post-radiation change. But don't forget, or let's not forget, it is where the primary mass, the enhancing nodule definitely resides where the primary mass was. So in that case, we had to give differential diagnosis, post-treatment change versus local recurrence. Please do short-term follow-up. And lucky enough in that case, the 6 months follow-up showed partial resolution and 12 months follow-up showed total resolution of the enhancing nodule. So what were the problems we have encountered in this patient? FDG PET for evaluation of the local disease was not the greatest radiopharmaceutical to be used because of the lesion to background ratio. And on the other hand, we wished we had a better imaging tool at the post-radiation 3 months follow-up that we could have used to identify or to differentiate the post-radiation change from the local recurrence. And that brings us to our case number 2. This patient is an elderly gentleman. He has been treated with resection and radiation many years ago. He has been symptom-free for almost a decade and disease-free for almost a decade, but he presents with low back pain. And we have scanned him on the same day with face MRI and the FDG PET-CT of the whole body. What we're looking at here is post-treatment related encephalomalacia and gliosis of the inferior frontal lobes, and hyperostosis of the sphenoid sinuses, but there is no local recurrence. And the lack of recurrence is also supported by FDG PET. We don't see any abnormal FDG uptake at the anteroskull base. However, I think this is convincing for everyone that the patient, no wonder why the patient had low back pain. We are looking at widespread sclerotic metastatic bone disease on this FDG PET-CT of the whole body. And we run into a very similar issue with the brain cortical uptake. Look at the bone background. On PET-only images, it's hard to differentiate what is metastasis, what is physiologic activity of the bone marrow. But when we combine it with CT images, I think it becomes a more powerful tool about regarding which one is metastasis and which one is not. So we have encountered a similar problem. The lesion to background ratio, but this time it's not the brain. It is the bone marrow physiologic activity. And at the same time, this patient has been disease-free for almost a decade. And sometimes we think we wish we had better imaging tools that could have predicted the treatment failure and identified this patient or those patients who would develop metastases in the future. And let's take a look if we have any answers to those questions. That brings this molecular imaging concept. We are looking at a radiotracer model. We have a radionuclide, which provides the PET imaging signal. It's linked to a biologically active molecule, which has a specific target in the body. In the case of gallium dotatate, the radionuclide is gallium-68, which provides robust PET signal for imaging. It is linked to the octreotase, which is a peptide in this case, which binds to somatostatin receptor type 2 in the body. And any tissue that overexpresses the SSTR2 subtype, the SSTR2, will be tagged or will be targeted by the gallium dotatate. But after seeing the molecule, let's take a look at the physiologic distribution, because we don't want to be fooled by the physiologic activity. The dotatate PET concentrates in the abdominal organs, but it's also taken up by the pituitary gland. But the beauty of the dotatate PET is complete lack of brain cortical activity. And in cases like Ostiomeatal Neuroblastoma, when we deal with skull base lesions, lack of brain activity makes everything much more easily recognizable. And that brings us to the concept of which masses of the head and neck express somatostatin receptor type 2, which is the main target of the dotatate PET. Those are the head and neck paragangiomas, skull base meningiomas, osteoneuroblastoma, pituitary pathologies, and the medullary thyroid cancer. Let's have a closer look to osteoneuroblastoma, which is our topic. This is a dotatate PET-CT done as baseline staging. The beauty of lack of brain cortical activity creates an excellent lesion to background ratio and identifies only the site of the disease. It's a right cribriform plate ethmoid sinus mass, and there is no nodal or distant metastatic disease. As you can clearly see here, the lesion to background ratio is excellent, driven by the lack of brain cortical activity, and identifying the full extent of the disease is pretty easy. Another case, this is a direct side-by-side comparison of the gallium dotatate, seen here, PET, with FDG PET. The lesion to background ratio and the lesion to background ratio. You can barely see, if at all, which I cannot, on this FDG PET. It's a perfect scenario to hide the mess. When we look at the comparison on fused images, on axially fused images, just sphenoidal esthesioneuroblastoma on the dotatate PET is excellently delineated by the dotatate activity, because the esthesioneuroblastoma overexpresses somatostatin receptor type 2. However, look at the FDG PET. We see a mass, but we cannot really tell where it starts and where it ends, because it's completely blending in with the activity of the brain cortex. But both dotatate PET and the FDG PET are concordant to show no nodal disease and no metastatic disease. After seeing the utilization of dotatate PET in baseline imaging, let's take a look at the post-treatment follow-up. This is almost reminiscent of a bone scan because of the widespread bone metastases on this dotatate PET CT. It resembles like a bone scan. And that is one of the very unlucky circumstances where esthesioneuroblastoma, despite our understanding of the local disease, how bad it could be, it could really get nasty in the bones as well. And the dotatate PET provides a full spectrum of disease response follow-up. On 4 different time point images, I think you can appreciate the decreased number of lesions and the decreased number of radiotracer uptake and decreased intensity of the radiotracer uptake, which is clearly demonstrating favorable treatment response. So, is the treatment response only useful for distant metastatic disease? Let's answer that question. It's clearly seen here. This is an inoperable esthesioneuroblastoma of the skull base, orbital compartments, as well as the nasal cavity and paranasal sinuses. So at baseline, the dotatate PET has shown this extensive dotatate activity, and at 3 different time point imaging, you can see that the extent of the activity shrunk, and the intensity has also got better. So dotatate clearly shows local treatment response, and it functions equally well in demonstrating diffusely metastatic bone disease treatment response, as well as locally aggressive inoperable disease treatment response. And time for some questions. Which of the organs is not a physiologic site for gallium dotatate uptake? And that organ, as I try to emphasize, makes this dotatate PET an excellent imaging tracer, radio tracer, to evaluate the skull base masses which overexpress a certain type of somatostatin receptor, and that is the brain cortex. And our next question: which of the somatostatin receptors is the primary target for gallium dotatate? And lucky enough for the neck cases, this receptor is overexpressed in all these 5 head and neck pathologies, and that is the somatostatin receptor type 2. In summary, esthesioneuroblastoma at baseline imaging for surgical planning is best imaged with CT or MRI. The success of surgical planning heavily depends on the success of anatomical information coming from the pre-surgical imaging, and MRI and CT, they function equally well for that purpose. However, when we talk about the whole body imaging in the metastatic disease workup, either at baseline or follow-up, as well as the systemic and local treatment response evaluation, gallium dotatate PET has a critical value and holds a future promise in the esthesioneuroblastoma imaging and treatment response follow-up. Thank you very much for listening, and I hope you enjoyed the talk. Please feel free to reach out if you have any questions. Thank you again.
Our final speaker is Dr. Benjamin Huang from University of North Carolina at Chapel Hill, who will be speaking about failed functional endoscopic sinus surgery.
Hello, I'm Ben Huang from the University of North Carolina. To finish out this session, I'm going to be talking about functional endoscopic sinus surgery with a focus on a few important causes of surgical failure that we as radiologists may be able to identify on postoperative sinus imaging. So here are our objectives for this talk. By the end of this lecture, you should understand the basic rationale and goals of functional endoscopic sinus surgery, also known as FESS. You should have a general idea of how common FESS procedures are done and be familiar with the expected appearance of the paranasal sinuses post-FESS. And finally, you should be aware of some of the more common causes of FESS failure and be able to identify them on a post-op sinus CT. Now, FESS is currently considered the treatment of choice for patients with medically refractory chronic sinusitis, which we can basically think of as being due to a self-perpetuating cycle of sinus mucosal inflammation, osteal obstruction, and impairment of normal mucociliary function, leading to chronic sinus infection. And left untreated, the process can cause irreversible damage to the mucosa and underlying bone of the affected sinus. So the goals of sinus surgery are basically to try to reestablish physiologic sinus ventilation and drainage and to restore normal mucociliary function. And this is done by attempting to widen the natural ostia of the involved sinuses, by removing any irreversibly diseased mucosa and bone, which could potentially serve as a nidus for continued inflammation, and finally, by leaving intact, whenever possible, healthy mucosa to preserve normal mucociliary function. Now, in this day and age, virtually all sinus surgeries are done endoscopically, hence the E in FESS. So sinus surgeons have at their disposal a variety of endoscopes of varying lengths and viewing angles, as well as a number of surgical instruments that allow them to safely widen sinus ostia and safely dissect bony partitions. The primary target in the vast majority of FESS procedures, of course, is going to be the Ostiomeatal Complex, or OMC, the anatomy of which has already been covered in detail previously, so I'm not going to spend any time reviewing it today. The main point to emphasize, though, is that the OMC represents the final common drainage pathway for the maxillary, the anterior ethmoid, and the frontal sinuses, and as a result, even a relatively small amount of inflammation in the OMC can lead to disease involving all three of these sinuses. So it would also make sense that opening the OMC up should improve the drainage of these sinuses as well. So how exactly do the surgeons do this? Well, in these next few slides, we'll run through the basic steps involved in performing a complete or full house FESS surgery. Keep in mind, though, that most patients will not undergo a total FESS procedure on their first go-round. Typically, primary FESS surgeries will be limited to the sinuses of concern, usually those draining into the OMC, but hopefully these slides will help you to conceptualize what each of the steps entail and what we should expect to see after they're done. So the first step in most FESS surgeries is to medialize the middle turbinate, which helps to improve surgical exposure in the middle meatus. The next step is to resect the middle portion of the uncinate process, basically that portion that makes up the floor of the ethmoid infundibulum, which exposes the natural maxillary ostium. And once the ostium has been identified, an antrostomy is performed to widen it. In this step, it's critical that the antrostomy incorporate the natural os, and we'll talk about why this is important a little bit later on. Once the antrostomy has been completed, the next step is to perform the anterior ethmoidectomy. To do this, the ethmoid bulla is opened to expose the other anterior ethmoid air cells. In the parasagittal plane, the ethmoid bulla sits above the hiatus semilunaris. As this and the other anterior cells are removed, the surgeons will eventually reach the basal lamella of the middle turbinate, which is the landmark that divides the anterior ethmoids from the posterior ethmoids. At this point, if disease is limited to the anterior sinuses, the surgeon may elect to leave the posterior ethmoids and sphenoid sinus alone and proceed with completion of the anterior ethmoidectomy and frontal recess dissection. If they decide to continue posteriorly, they'll take down the oblique portion of the basal lamella to enter the posterior ethmoids and then clear any posterior ethmoid septations until they reach the anterior wall of the sphenoid sinus. In the axial plane, here we can again see the basal lamella separating the anterior and posterior ethmoids. Once the posterior cells have been opened, the surgeons can see the anterior wall of the sphenoid sinus and locate the sphenoid ostium, which can be found just medial to the superior turbinate opening into the sphenoethmoidal recess. If necessary, a sphenoid sinusotomy can then be performed to widen the sphenoid ostium. Now, at this point, the skull base should be easily identifiable, and the surgeons will typically then proceed with completion of the ethmoidectomy to remove any residual ethmoid septations along the anterior skull base and lamina pepritia. Finally, the frontal recess is addressed with removal of the upper portion of the uncinect process and any air cells in the frontal recess region. So after a total or full house FESS, this is what we should expect to see on a post-op CT scan. On these coronal images going from anterior to posterior, we can see that the uncinect process and ethmoid bulla have been completely removed and that the maxillary ostium has been widely opened. On the middle image, we can again see widely patent antrostomies and no appreciable ethmoid septations. Note the discontinuity of the oblique portions of the basal lamellae of the middle turbinate, which indicates that the posterior ethmoids have been entered. Even more posteriorly, the posterior ethmoids have been completely removed. Note how on all three images there are virtually no residual ethmoid septations visible. Switching to the axial plane, the image on the left demonstrates widely patent antrostomies. Notice that the uncinect processes have been resected to where they would normally insert on the posterior walls of the lacrimal ducts, behind which is where the natural ostia normally reside. The image on the right shows complete removal of the anterior and posterior ethmoid septations and widely patent sphenoid sinusotomies. Finally, the parasagittal image demonstrates complete removal of the ethmoid air cells along with the oblique portion of the basal lamella. The frontal recess is widely patent, as is the sphenoid sinusotomy posteriorly. And in this slide, we can see the differences between an anterior ethmoidectomy and a total ethmoidectomy. This patient had just his anterior ethmoids dissected on the right and both anterior and posterior ethmoidectomies on the left. Notice on the right side how we still have an intact basal lamella as well as the posterior ethmoid septations. On the left side, the basal lamella has been removed, along with most of the anterior and posterior ethmoid septations. In addition, a sphenoid sinusotomy has been performed with a widely patent sphenoid ostium. So now that we're all familiar with the typical post-FESS appearance of the sinuses on CT, let's turn our attention to some of the potential causes of FESS failure. Fortunately, when coupled with adequate medical management, primary FESS procedures produce durable treatment responses in the vast majority of cases. However, about 10 to 15% of patients undergoing primary FESS will fail their initial surgery, requiring them to undergo one or more revision surgeries down the road. So why exactly does this happen? Well, the potential causes of FESS failure can generally be divided into three main categories. The first consists of cases in which there is persistent obstruction or residual diseased tissue due to an incomplete or inadequate FESS surgery. The second category consists of patients who recur despite a complete or technically adequate FESS. In these situations, obstruction may recur for reasons beyond the surgeon's control. Finally, FESS procedures can fail if the symptoms prompting the surgery were actually due to non-sinogenic causes. For instance, cases in which patients had headache or facial pain that was due to ojonogenic or TMJ causes rather than sinus inflammation. Now, because of this possibility, it's always important for you to look for and to mention these non-sinogenic pathologies on your sinus CT reports, though I'm not really going to cover them specifically today. Instead, I'm going to focus our discussion on the entities in these first two categories, starting with findings associated with incomplete FESS. The first of these that we'll cover is an entity that is well recognized by sinus surgeons and has been referred to as a missed maxillary antrostomy or missed ostium sequence. This occurs if the surgeon inadvertently creates their antrostomy in the wrong location without incorporating the natural ostium, or if they perform an antrostomy in the correct location but fail to incorporate any pre-existing accessory ostia into it. If these occur, patients can continue to have symptoms, either due to unresolved obstruction at the natural ostium or because of a phenomenon known as mucus recirculation. Now, to understand the concept of mucus recirculation, you have to remember that normal mucociliary transport within the sinuses moves secretions only in the direction of the natural ostium. So when there is a misplaced antrostomy or an unrecognized accessory ostium, the mucus that is initially transported out of the natural ostium may be swept back into the sinus via that second opening. From there, the mucus is directed back towards and then out of the natural ostium again, causing it to repeatedly recirculate in and out of the sinus. This repeated presentation of potential irritants within the recirculated mucus can induce mucosal inflammation, leading to continued symptoms. And it turns out the surgeons can actually see this mucus recirculation phenomenon on endoscopy. The top endoscopic image here demonstrates a band of recirculating mucus extending from the natural maxillary sinus ostium anteriorly to a misplaced antrostomy posteriorly. The bottom image shows the anatomy after the mucus was suctioned and reveals a band of tissue separating the two openings. In order to address recirculation in this case, this band of bone and mucosa needs to be resected to create a single large antrostomy that includes both ostia. And here we have a CT example illustrating findings of a missed antrostomy. On the posterior-most coronal image, we can see evidence of bilateral antrostomies. But if we move just a little bit further anteriorly, we start to see soft tissue and bone spanning the antrostomy on the right, also seen on the axial image here. And on the anterior-most coronal image, which is at the level of the natural ostium, we can see a remnant of the uncinate process medial to the ostium, as well as a remnant of the floor of the ethmoid bulla just above it. Remember that what we want to see normally in the post-antrostomy setting is something that looks more like this, in which the uncinate process and ethmoid bulla have been completely removed and the natural ostium has been widened. If instead we can see those normal structures on a side that is supposedly undergone a maxillary antrostomy, generally that's a bad finding and suggests that the antrostomy was misplaced or fails to completely incorporate the natural ostium. Now, in addition to contributing to unaddressed obstruction at the level of the maxillary ostium, as we just saw, failure to completely remove the uncinate more superiorly can also contribute to persistent obstruction at the frontal recess. Remember that a portion of the uncinate process continues upward to attach to either the lamina papyracea, as we can see on the top image, or on the middle turbinate or anterior skull base, an example of which is shown on the bottom image. In either case, the superior portion of the uncinate contributes a boundary to the frontal recess, so if there is disease affecting this region, failure to completely remove that superior portion of the uncinate during surgery can result in unresolved frontal recess obstruction. And here we have just such an example. This is a patient who had undergone several sinus surgeries previously. It looks like the patient had some attempt at both anterior and posterior ethmoidectomies and possibly maxillary antrostomies. However, again, if we go more anteriorly to the level of the natural maxillary ostia, we notice that the inferior portions of the uncinate processes are still present and that the ostia appear untouched and are opacified, similar to the case that we saw earlier. Not only that, on the slice just anterior to this, we can see that the superior portions of both uncinate processes are still present, attached to the orbital laminae bilaterally, and forming the lateral boundaries of the frontal recesses, which are also opacified. So in this case, failure to remove the uncinate processes resulted in continued obstruction both at the maxillary ostia and at the frontal recesses. Another finding that is commonly seen in patients undergoing revision FESS is middle turbinate lateralization. If you'll recall, one of the first steps in FESS procedures is to medialize the middle turbinate for better exposure. However, if the surgeon is too aggressive in their manipulation of the turbinate, particularly if they injure the vertical or horizontal attachments of the basal lamellae, this can lead to destabilization of the turbinate, which can predispose it to migrating laterally postoperatively and potentially scarring down against the lateral nasal wall or lamina papricia. These can lead to blockage of the middle meatus, the frontal recess, or the ethmoid complex. So here we have an example. This patient had bilateral FESS procedures several years earlier, but eventually developed recurrent symptoms. His CT at the time showed complete right frontal sinus opacification. In this case, the coronal and axial images give us an example of what's actually going on. On the coronal image, we can see the middle turbinate has become lateralized and now butts the lamina papricia. And on the axial image, we can see the anterior aspect of the turbinate bowed laterally, narrowing the frontal sinus outflow tract. This patient underwent revision surgery with resection of that portion of the turbinate, reestablishing patency in the frontal recess. Here's one additional example in a patient who underwent bilateral maxillary antrostomies. The patient was having recurrent symptoms on the right, and their CT showed the head of the middle turbinate displaced laterally into the antrostomy and obstructing the opening of the middle meatus. This patient also underwent revision surgery, which included partial middle turbinectomies with reestablished patency of the right antrostomy and middle meatus. Now, the last cause of FESS failure related to incomplete surgery that we'll cover today is probably the most common, and this is incomplete ethmoid dissection. Now, as I mentioned earlier, while it's not necessary to perform a total ethmoidectomy in every patient, once the decision has been made to address a particular group of sinuses, that group should be completely dissected. The reason being that any leftover cells or septations could contribute to continued obstruction in that region or serve as a nidus for persistent inflammation. Now, this can affect the anterior or posterior drainage pathways and can also include incomplete resection of variant cells, such as we can see in the top case where we have an incompletely resected Haller cell obstructing the maxillary ostium on the right. Now, that said, the most common site to see persistent obstruction due to incomplete ethmoid dissection is actually in the region of the frontal recess. So this is the area that we'll focus on today. Now, most of you are probably already familiar with the classification of frontoethmoidal cells that was initially described by Bent and Kuhn back in the early 1990s. What some of you might not be as familiar with is this 2016 consensus document known as the International Frontal Sinus Anatomy Classification, or IFAC. This scheme was developed by a consortium of sinus surgeons in order to standardize the nomenclature of ethmoidal cells in the frontal recess region. And it was based largely on that early work by Kuhn as well as other authors. To briefly summarize, the IFAC divides frontal recess cells into three groups based on their location relative to the frontal recess: an anterior group, a posterior group, and a medial group. The anterior group consists of cells along the anterolateral aspect of the frontal recess and includes the agarnaceae as well as those cells lying just above it, including what are known as supraagar cells, which correspond to Kuhn type 1 and some type 2 cells, and supraagar frontal cells, which are cells above the agarnaceae that extend into the frontal sinus and correspond to the remaining type 2 as well as type 3 and type 4 cells. The posterior group consists of cells located along the posterior wall of the frontal recess just above the ethmoid bulla and includes the suprabulla and suprabular frontal cells, which are distinguished from one another based on whether they extend into the frontal sinus or not. This group also includes supraorbital ethmoid cells, which are similar to suprabular frontal cells, but actually extend further laterally to pneumatize the orbital roof. Finally, there's one type of medial cell known as the frontal septal cell, which represents a cell pneumatizing the frontal sinus septum. So in a patient with significant frontal sinus disease, leaving any of these cells behind can lead to surgical failure in that region. And here we have a few examples. In the case on the left, we see evidence of a previous anterior ethmoidectomy, but the frontal sinus is still mostly opacified. And notice this septation just below the frontal ostium, which represents the residual roof of one of those anterior frontal recess cells, which in this case was partially obstructing the frontal outflow tract. In the middle case, we can see evidence of prior ethmoidectomy with residual opacification of the frontal sinus. Hopefully you can see the large opacified supraauger frontal or type 3 cell extending into the frontal sinus, its ostium, and frontal recess. In addition, along the posterior wall of the frontal recess, we can see another strut of bone representing the residual anterior wall of a suprabulla cell. Finally, the example on the right demonstrates a large opacified suprabulla frontal cell projecting upward along the posterior wall of the frontal sinus, narrowing the frontal ostium and recess from behind. In all of these cases, the surgeon would want to clear out all of these septations in order to reestablish patency of the frontal ostium and frontal recess. Now, to finish things off, we'll cover a few entities that can contribute to treatment failure in spite of a technically adequate surgery. These essentially consist of things that may reobstruct sinus drainage pathways after they were initially opened surgically, with the frontal ostium and frontal recess again being the areas that are generally most commonly affected. Now we can basically divide these entities into two categories, the first being those that appear as soft tissue density on CT, and the second being processes that form new bone, also referred to as neoosteogenesis. Entities in the first category include things like scar tissue, recurrently inflamed and edematous mucosa, and recurrent polyps. And generally speaking, it can be difficult or impossible to distinguish these soft tissue density entities on CT unless we have a picture like the one shown here, in which there are clearly multiple mass-like polyps emanating from and obstructing the sinus. Frequently, however, we may get a case that looks like this, in which the sinus ostium is obstructed by soft tissue, but we really have no idea whether we're dealing with scar tissue, inflamed mucosa, a polyp, trapped mucus, or some combination of all of them. All we can do in this case is simply to state in our report that there is soft tissue opacifying the frontal sinus and frontal ostium, and it's up to the endoscopist to get to the bottom of what that tissue actually represents. Now, on the other hand, neoosteogenesis is fairly easy for us to diagnose. It's a common finding in post-op sinuses and basically refers to the presence of osseous overgrowth along the walls or residual septations of the sinuses. Typically, it's due to a combination of mucosal trauma from surgery along with persistent inflammation or infection. And it can become problematic either if the bone becomes thick enough to primarily obstruct sinus ostia, or if it serves as an inflammatory nidus that induces overlying mucosal edema, which in turn causes ostial narrowing. Now, these images demonstrate one of the nicer examples of neoosteogenesis I've encountered recently. This patient had a comprehensive frontoethmoidal dissection. However, the frontal sinus is completely opacified. In this case, because of the formation of these thick chunks of new bone, which have grown into the frontal sinus and obliterated the frontal ostium. Now, reopening the sinus is going to entail drilling out all of that bone, which can be extremely challenging and hazardous for the surgeon, so they're definitely going to want to know about the presence of significant neoosteogenesis ahead of time. So let's wrap up with a summary of what we covered over the last 20 or so minutes. We started with an overview of the steps involved in FESS procedures, and I hope that you will all have a good idea now of what the desired outcome should look like on a postoperative CT. We covered some of the more common causes of FESS failure that we may encounter on imaging. These include factors related to incomplete surgery, such as a missed maxillary antrostomy, incomplete uncinectomy, middle turbinate lateralization, and incomplete ethmoid dissection, as well as entities leading to recurrence following a technically adequate surgery, usually the development of some sort of obstructing soft tissue or neoosteogenesis within a previously opened sinus ostium. By looking for and describing these findings when present, hopefully you'll be able to provide a little bit more value in your post-FESS CT reports. So with that, I'll conclude. If anyone out there has any questions after this session, feel free to shoot me an email at this address. Thank you all for tuning in.